Evening, doctors. It gives me great pleasure to welcome you all to this scientific meeting. We are honored to have Dr. Ram Abhinav sir, consultant medical oncologist from KMCH Hospital, Coimbatore, with us today. He will be sharing his insights on the evolving management of metastatic hormone-sensitive prostate cancer and the importance of early treatment intensification. I am sure the session will be highly informative and clinically relevant. Thank you for joining us. Over to you, sir.
Thank you. I hope my slides are visible.
Yes, sir. Perfect, sir.
So from HSPC to metastatic CRPC, can we delay the inevitable is the question. So these slides are given by Bayer. And just a minute. Okay. So the standard of care for any metastatic HSPC is androgen deprivation therapy plus one of the ARPI. Irrespective of the timing of metastasis, the risk, volume, burden, and co-administration of docetaxel, sometimes with or without radiotherapy. There is no role for intensification with docetaxel alone, as demonstrated by PEACE-1 and Arasens. So, coming to the various earlier strategies, how intensification was tried. So that was with the docetaxel. So there are 3 studies, Mr. Charted, the Stampede, and the GETU. All 3 showed that the addition of docetaxel to androgen deprivation therapy led to significant improvement in the disease relapse and even overall survival. So coming to what EUA thinks at this point of time. So if we see a prostatic adenocarcinoma, which is metastasized, we should consider continuous castration, which is either surgical or a medical. And if there is adequate life expectancy, you need to categorize them to low volume disease and high volume disease. And by high volume disease, what they mean is more than 4 bone metastasis, including more than 1 outside the vertebral column, or pelvis, or visceral metastasis. So, and if they are eligible for docetaxel, then based on that, you categorize them into double continuous systemic therapy, that is uh, continuous castration with one of the ARPIs, or you consider for triple, that is continuous castration with docetaxel with abiraterone prednisolone or docetaxel with daralutamide. So why and who is eligible for docetaxel? So when you look at the data, effect of docetaxel on the overall survival by the volume and timing of metastatic disease, the diagnosis, volume, and T stage. But you can see that low volume and metachronous, not much of a benefit, whereas low volume and synchronous, the graph is more favorable. High volume and metachronous, yes, there is a benefit. Whereas high volume and synchronous, definitely there's a benefit, not even touching the unity. And that is probably why this graph, which subset which derives the maximum benefit from docetaxel. And when you look at the effect of docetaxel on OS for patients with high volume disease, T stage 1 to 3, yes, there is benefit, but not very significant. But when there's a T4 stage, then there's a significant benefit with the addition of docetaxel along with androgen deprivation therapy. So the standard of care for any metastatic hormone-sensitive prostate cancer is androgen deprivation therapy with one of the ARPI, and irrespective of the timing of metastasis, risk, volume, or burden, and coordination of docetaxel in radiotherapy, there is no intensification with docetaxel alone, as demonstrated by PIECE-1. So now coming to the Harrison study. So Harrison study was the only study prospectively designed to investigate the combination of daralutamide with ADT with docetaxel in metastatic hormone-sensitive prostate cancer. So it was a global randomized double-blind placebo-controlled phase 3 study, and number of patients were 1,306. These patients were metastatic HSPC epoch score of less than or equal to 1, and they were candidates for ADT and docetaxel. And the stratification was based on the extent of disease, M1A versus M1B versus M1C, and the alkaline phosphatase level less or more than the upper limit of normal. And these patients were randomized to docetaxel with daralutamide and ADT, or placebo with ADT and docetaxel. So it was a 1:1 randomization. The primary endpoint was overall survival, and the secondary endpoint was time to castration-resistant prostate cancer, time to pain progression, time to symptomatic skeletal-related event survival, time to first symptomatic skeletal event, time to initiation of subsequent anti-neoplastic therapy, time to worsening of the physical symptoms of disease, time to initiation of opioid use for more than 7 consecutive days, and safety. And the final analysis was conducted up to 533 deaths. The secondary endpoint efficacy were tested hierarchically. First cycle was docetaxel was administered within the first 6 weeks. So coming to PIECE-1 was not prospectively designed to investigate the combination of abiraterone prednisolone with docetaxel. So it's metastatic HSPC, which included only de novo M1 disease, recurrent M1, and prior chemotherapy were excluded. And disease extent definition was based on high and low volume, and performance status was less than 1. And they need to have less than 3 months of ADT prior to randomization and no prior cytotoxic chemotherapy or biological therapy. And the stratification was based on epoch P as 0 or 0 to 1. 1 to 2, metastatic sites, lymph node versus bone versus visceral, the type of castration, and docetaxel. And when we come to the pooled standard of care group, that is Arm A is standard of care and Arm C is standard of care plus radiotherapy. Whereas pool ABI group is standard of care with abiraterone plus prednisolone, and Arm D is standard of care with abiraterone, prednisolone, and radiotherapy. So SOC means ADT or ADT with docetaxel. And the primary endpoints was overall survival and radiographic progression-free survival. And secondary endpoints included CRPC survival, serious genitourinary event-free survival, prostate cancer specific survival, time to next skeletal related event, PSA response rate, PSA at 6 months and 8 months, initiation of standard of care, time to pain progression, time to chemotherapy for CRPC, quality of life, toxicity, changes in bone mineral density, correlation with biomarkers with outcome, event rate per 100 years of treatment. So it is an open label study with 2:2 factorial design. So the PIECE-1 was amended to allow for the evolving standard of care with docetaxel. So November 2013 to 15, it was ADT alone, which is considered standard of care. Whereas 15 to 17, docetaxel was permitted as a standard of care. And 2017 to 18, docetaxel was a mandatory as a part of standard of care. But in comparison, Addison's was a clean study where all 1,306 patients enrolled received docetaxel versus only 710 patients which received docetaxel in piece 1. And duralutamide is the only ARPI prospectively tested and proven in combination with docetaxel plus ADT to prolong survival and delay disease and pain progression-free survival in both de novo and recurrent HSPC. So when we just a quick comparison where Addison's recurrent and de novo disease were included, whereas piece 1 only de novo. Primary endpoint is OS and OS, and stratification factors as discussed earlier. And docetaxel with ARPI, here 100% of the patients received, whereas here the 61% of the patients received. And I'm not discussing in detail about the exclusion criteria because basically these patients were not fit. In the Addison's group, daralutamide with ADT with docetaxel significantly reduced the risk of death by 32%. So with addition of daralutamide, the 4-year survival rate increased from 50% to 63%, which was very, very significant. And the hazard ratio for overall survival for placebo ADT was 0.68, and the confidence interval was between 0.57 to 0.80. The p-value was very significant. So there is validity of early treatment intensification with combination, which is supported by the results from the piece 1. So we can see that there is an early separation which occurs as early as around 1.5 years. And the median overall survival for abiraterone, prednisolone, ADT, and docetaxel, the median was not reached. And the docetaxel, it is around 4.4 years. The abiraterone docetaxel actually improved significantly OS compared to docetaxel. But unlike in piece 1, in Addison's, there was a early separation in the Kaplan-Meier curve. The line remains separated over time. So the patient in daralutamide arm stayed on treatment for more than 2 years longer than in the placebo arm and had similar discontinuation rates due to AE. We can see from here. So the discontinuation rates are very low, it's around 10% in both the arms. And the duration of treatment discontinuation is higher in the abiraterone arm in the piece 1 trial, around 17% or so, less than 1%. So daralutamide did not affect the ability to complete the full 6 cycles of docetaxel. So around 87% of them completed in both, approximately in both the arms. Piece 1 does not report the proportion of patients who completed all 6 cycles of docetaxel. In Harrison's, the incidence of any grade adverse events were similar in both the arms. You can see that it's exactly matching both the sides. Whereas in piece 1, the grade 3 or more adverse events were higher in the abiraterone plus NADs, with severe risk of severe hypertension and hepatotoxicity compared to docetaxel. And one of the most common underrated side effect is the hepatotoxicity. So when it happens, generally causes grade 3 transaminitis and hyperbilirubinemia. Sometimes we might have to stop the treatment, and also hypertension. So the grade 3 or more adverse events were approximately around 15% more when the abiraterone piece 1 arm. In the Addison's, the instance of adverse event of interest were similar between the 2 arms. You can see that most of them are very, very comparable between the 2. So the incidence of rash and hypertension were higher in the daralutamide arm than in the placebo arm. So the standard of care for any metastatic HSPC is ADT and one of the ARPI, irrespective of the timing of metastasis, risk, volume, burden, co-administration. There's no role of intensification as demonstrated by Peaceman and Harrison's. The APCCC 2004 panelists voted on questions regarding the use of the systemic triplet therapy. In patients with high burden metastatic HSPC that are chemotherapy fit, do you recommend the triplet therapy ADT plus docetaxel plus ARPA? Around 54% said yes, and around 40% in selected patient, and only 6% said I would not recommend this combination. So in patients with low burden HSPC that are chemotherapy fit, do you recommend triplet plus ADT? Was another question. Again, majority said yes, 50%, yes in selected patients, 47%, no, only 3%. And asynchronous disease was similar pattern, where majority of them agreed to go ahead with the triplet therapy. Safety concerns for doublet and triplet therapy. Monitoring with laboratory hypertension, edema, LFTs, and hypokalemia. Pill burden, exacerbation of the ADT, adverse event, cardiovascular, cognitive, and bone health. Triplet therapy includes the infusional treatment, the chemotherapy toxicity, the administration time, and the other considerations which are generally associated with the doublet therapy previously discussed. So take-home message is that the two studies, PEACE-1 and Harrison's, demonstrated that ADT plus docetaxel is not enough, and that addition of ARPI improves survival. The additional intensification with triple combination approach should be considered as the new standard of care. So to proactively manage adverse event of new treatment options and to optimize new treatment outcomes, quality of life, and survival, multidisciplinary care are key to success. All eligible patients should be offered the benefits of all proven and effective treatment, enable living with preserved and improved quality of life. With that, I will conclude my talk. And if there are any questions, I'll take. And before I finish, so of late, I've had recent usage of darolutamide with chemotherapy and ADT. So with my personal experience, I could share with the limited experience, 3 to 4 patient experience, that it is pretty much doable. I do not see any significant significant worsening of toxicities. And most of these patients are performance status 2. They are not even performance status 1. And most of them tolerate both chemotherapy and darolutamide, the combination, pretty well. So that is nice to see, because you don't get extra side effects, but you get improved outcomes. That I'll conclude my talk, and I'll open for any questions.
Thank you, Doctor. Thank you much for your kind words and insightful discussion on darolutamide. I think there is no questions from the audience side, sir. I hope you all shared their experience. That is what we are going to ask with you, sir. So once again, thank you very much for giving such a positive word. Thank you, Doctor. We'll wait for a single minute. The audience side, sir. Shall we conclude the meeting, sir? So thank you, Doctor, for your valuable insights, and thank you for all your participation, Doctor. Thank you, sir.
Thank you.
Thank you. Tech support team.